weekend. And just want to say that if you were celebrating Passover, I hope you had a happy Passover, Chag Sameach, happy Easter. If you're celebrating or observing Ramadan, I hope you have a meaningful fast. And hope you enjoyed the long Maine, Massachusetts Patriots Day weekend. So today we're going to be talking about two cases in stress imaging. And this was born out of two cases that were kind of interesting and in some cases challenging from the patient management perspective in as far as interactions with the patients based on the results. These cases illustrate the importance of being able to recognize some features of stress testing that you don't always see every day. And it also illustrates the importance of good team communication. So that's what we wanted to illustrate today for you. There will also be an opportunity to discuss a couple of other items that these cases bring up. This is meant to be kind of a launching point. It's come to our attention that there's a lot of need for education around stress testing and stress imaging. And in fact, there's a health system-wide initiative to standardize supervision of stress testing. And so I anticipate that this will be one of many conversations that we'll probably be having in the coming weeks and months. So first, I want to introduce Jean Cass, who's sitting to my left. Some of you know her, some may not. Jean is a nurse practitioner here in our Scarborough office, has been working here for quite a long time. I've lost count of how many years.
Almost 10.
Oh, it's amazing. I just want to tip my hat to Jean. She was involved in these cases and did just a stellar job pulling them together for you this morning. So I want to thank Jean for doing all of this work to put this together. And thank you also, Andrea, for setting up the Zoom call and in the invitations to everyone. So without further ado, I'm going to share the screen here. And you should see the first slide. So this is what they're seeing.
Okay.
And then this tells you what the next slide will be. So
Okay.
you can see what's going on here.
Great.
Okay. So take it away, Jean.
Good morning, and thanks for the feedback, Dr. Cohen. Our first case is a stress echocardiogram. And this is a gentleman who was referred for a stress echo by his primary, and this was before a surgery. He's actually has a lot of knowledge. He's been a nurse for decades, and he's a prior director of the operating rooms at Maine Medical Center. He has multiple cardiovascular risk factors, including hypertension, hyperlipidemia, diabetes, and known carotid stenosis. His stress testing goes way back. So in 2013, he had a Bruce and he reached 11 METs. His EKG was positive for ischemia, and his echo actually suggested distal LAD distribution ischemia. He was asymptomatic and declined cardiac cath. For the next couple of years and then some, he was followed by intermed cardiology, and he declined a cath, he declined calcium score, and canceled his 2017 stress echo. And back in April of 2021, intermed cardiology ordered the stress echo because he had chest pain and a prior history of an abnormal stress echo. He never scheduled it.
Just going to ask that if you're not presenting or asking a question, if you could just mute, please. Thank you. Go ahead.
So in mid-November, he was seen by general surgery because he wished to have a hernia repair. And then the PCP phoned the surgeon to say he really needed stress echo, which was ordered a year ago, but he didn't have it. So he said he's not going to have the stress echo, and his surgery was canceled. And in the middle of December, he agreed to a stress echo. So we all know how to read EKGs, and I'm just going to point out that, as we all know, we do an initial supine EKG. And his baseline, as I'm sure you know, is normal sinus rhythm. He has some Q waves in leads 3 and F, early transition, and poor R wave progression.
So I'm just going to go backwards for one so you can just see that one more time. This is the baseline ECG.
So this is his standing EKG, and we all know that this is what we compare to his following exercise. So already in stage 1, he has some downsloping of his ST segments and with ST segment depression.
And you're seeing this in multiple leads, Gene, aren't you? You're seeing this in 1, lead 2, lead not so much in lead 3, but you're starting to see some ST depression in 4, 5, and 6. So
and AVF as well.
And AVF, that's correct.
So this is at the beginning of stage 2, and we can see quite a bit of ST segment depression. And I probably don't need to point out the leads, but you can see them.
So all along here, you're even seeing some ST elevation in AVR. And he's asymptomatic at this point, right?
He was asymptomatic the entire test. This is at the end of stage 2 with ongoing ST segment depression, ST elevation, and AVR. And at peak exercise, this is pronounced, as you can all see, 2.5 millimeters downsloping ST segment depression in leads 1, 2, AVL, V2, again, completely asymptomatic.
So at this point, with this extensive amount of ST depression and without having any medications such as digoxin on board that would make this non-diagnostic, without the presence of left ventricular hypertrophy or a bundle branch block that would preclude interpretation, you have to interpret this as positive. Right?
Absolutely.
Well, it's not over yet though, right? So we're now going to monitor him in recovery.
So his ST segments and their depression persist here in 2 minutes of recovery. And by 5 minutes the same, he's adamant at this point that he is fine. 7 minutes of recovery.
So in 1 and L, you still have significant ST depression. If you just saw the ST depression in 2, 3, and AVF, here it's pretty much returned to normal in 3 and F, but you still have ST depression in lead 2, just a skosh in lead 5, but you still have significant ST depression in 1 and L.
So it was about almost 16 minutes by the time his EKG changes resolved. He was adamant about the fact that he was well. And in summary here he went 6 minutes and 26 seconds, and which is 7.5 METs. He reached the 3rd stage and stopped the exercise due to shortness of breath. Again, he was completely asymptomatic. And from an ectopy standpoint, he had a few or several short runs of atrial tachycardia and occasional PVCs. He did not wish to wait for review by the cardiologist. That was Dr. Cohen.
Okay, so at this point, what are people's thoughts as to how you might proceed? Now, obviously, this statement says declined waiting for review by the cardiologist. What that means is the person supervising the test, Jeannie, thought, that this person had a markedly positive ECG, was persistently positive in recovery. I really ought to have this looked at before the patient's allowed to leave the office. Unfortunately, the patient just said, I'm leaving. But I think that this does point out that what you're going to see is that when you have a pretty markedly positive stress test, we probably should get a handle on how abnormal the associated imaging is before the patient is allowed to leave when possible. Yeah, I'm going to go. So before we actually go over the images, we just want to point out a few things about the hemodynamics here.
Please go ahead.
Go ahead.
Yeah. No, you can go ahead.
Oh, me go ahead.
Yes,
okay.
please.
All
Thank
right.
you.
All right. So it's come to my attention that despite there being a lab standard about how you judge the appropriate hemodynamic response, there's some variability in how people are actually doing this. And I just want to say that it's actually been for several years that the physicians decided that they wanted a standardized approach based on the most up-to-date data. There are a number of labs, and we're trying to stamp it out, that still have, old, really ancient tables that are pasted to the wall or people are carrying some things in their pockets. But what I'm going to show you now is really the lab standard for how you determine whether a person has an appropriate blood pressure response and how you calculate the appropriate heart rate response. So this article really is the definitive article, fairly recent in 2019, and looking at what the appropriate blood pressure response is for both males and females. And the physicians who reviewed this data decided that we would like to simplify it to some extent. And there are lots of tables in this publication. If you're so inclined to take a look at it, I can help you out in getting it. But it boils down to gender specific normals and also based on what the initial blood pressure is. Hang on a second, I'm getting a message. I just have to say no. Sorry about that. Okay. So if the blood pressure starts out in a male less than 140, the lower limit of a normal change in blood pressure is 35 millimeters of mercury. So it should go up at least 35 millimeters of mercury, but not exceed 200. Likewise, for females, if it starts out less than 140, the blood pressure should go up at least 25 millimeters of mercury and not to exceed 190. If you start out hypertensive, though, you have a slightly less incremental increase in blood pressure change as normal. You are allowed to go up as high as 230 if you're male and 210 if you're female. What about heart rate? So I think you're all familiar with calculating the age predicted maximum blood pressure, and 85% of that is what we look for a diagnostic test. And so to calculate that, we take the patient's age, subtract that from 220 and multiply by 0.85. So this fellow, if you go through the motions of looking at this table, had a blood pressure response that was normal, barely. And certainly if a person has a blunted blood pressure response, you want to kind of take note of that. Could that be due to medications or other reasons, deconditioning maybe? But certainly if the blood pressure drops, that's a high risk marker. What about heart rate response? This is what everybody should be using now. These are posted in Scarborough now. They're part of the diagnostic reference manual that the physicians use and have at their fingertips at all reading stations. We will try to get this. This was sent out several years ago. It's now come to my attention that we really probably should send it out again. But there are two equations. These are based on very well conducted studies, and they're actually very easy to commit to memory. So for males, you take 0.15 times the age and you subtract that from 18. And for females, it's 0.13 times the age and subtract that from 14.7. And that gives you the number of expected METs. There are no, standard guidelines about this, but what we've generally done as the physicians interpret this is if you're within plus or minus 1 MET of this predicted amount of work capacity, that should be as predicted. If you're more than a MET under, then that's below predicted. And if you exercise for more than a MET beyond that, then that's above predicted. So in this case, he achieved 7.5 METs, but if you do the calculation, 0.15 times his age of 65, subtract that from 18, it was expected that he should exercise 9.75 METs. So he actually was below his predicted exercise capacity. So thus far, we have a patient who has a pretty markedly positive stress test, borderline blood pressure response, and is below his predicted exercise capacity. These are all red flags. So let's look at the images here. And let's see here. Hold on, I want to try to stop sharing and show something else. Whoops, don't want to show that yet. Why is this not? Bear with us here. Huh. Can't stop sharing the screen. Let's see. Black or unblack slideshow. Let's do it this way. There we go. Let's stop sharing. I was looking on the wrong screen. Okay, bear with me for just a second while I bring up Epic. Study review. Can you just read me? Give me that a session number. Where's the report? So I guess, yeah,
44 9
9
01
01
468.
468. Okay, these pictures have not been anonymized. I would characterize this as part of QA, but we certainly ask that you not share this patient information with people outside of the meeting. Waiting for the images to come up. All right, here we go. Hold on. I got share. Share screen. Screen 1. Okay. I'm hoping that you're seeing a stress echo in front of you right now. Can someone just confirm that for me?
Yes, we can see it.
Thank you. All right, so these are the baseline images, but I think what I'd like to do is I'm just going to show you the comparison images. So what we do is we have the resting images on the left side of the screen, and we have the stress images on the right side of the screen. Okay, so these are your resting images. These are your, on the right side, I'm hoping you're seeing the pointer, are the stress images. This is the peristernal long axis view. So this is the septum up here. We're not really seeing the infralateral wall that well. This is a short axis view. So we're slicing the left ventricle like a donut with the anterior wall up around 1 or 2 o'clock. The septum is over here at like 10 o'clock. The inferior wall is down here at like 7 o'clock. And the infralateral wall is down here at about 4 o'clock. And one thing that's already kind of apparent here is that if you look at the cavity size at the end of the squeeze, at the end of systole, the size is actually a little bit bigger here on stress. And that's of concern. And the other thing is that you can see this thickening very well here. So in your mind's eye, I've got the cursor on end diastole. Look how the endocardium goes well past the cursor towards the right. Now, if I look over here, it really doesn't go past the cursor, right? So you have a wall motion abnormality here. The apex becomes akinetic. And here we have the lateral wall. This isn't looking too good either. And you can see dilation of this LV here. This is the anterior wall here, and the kind of inferior septum here. This is the 2 chamber. So, and then the apex is akinetic. All right. So when you see chamber dilatation and kind of wipe out of the apical segments, maybe the apical half of the anterior wall and the apex and the apical portion of the septum, you're talking about pretty significant LAD territory ischemia here. This is a very high risk echo finding, and unfortunately, this really wasn't recognized by the echo tech. And we fed that back, and we'll be having a similar session for the echo techs as well. But we're so used to seeing stress echoes be normal because we so often apply them to low risk individuals for lots of reasons. And so you want to make sure that you don't get lulled into seeing what you want to see. You need to see what is actually in front of you. And this is an extremely concerning stress echo. Just to round it out, two more images. Ones don't show things quite as well, except for you can appreciate that here the apex is coming in very nicely, and here not so much. See, it's not even passing the cursor. So this was a high risk stress echo. So I'm going to go back to showing our slides, hopefully. Oh, wait a minute. I don't think you're seeing it yet. One second. There we go. Share screen. Screen one. You should be seeing a black screen now, and we're going to go to the next. And there we go. So, Jean, why don't you just tell everybody what transpired after that? Remember that the patient had left the office.
Not only had he left, but he essentially was refusing to come back to the hospital and said that nothing was wrong. And
so you called him.
I called him.
You were able to reach him on his cell phone. Right?
I did. I think initially we left a few messages, and ultimately I had him on speakerphone so that Dr. Cohen could chime in about the extremely abnormal test. And ultimately he was willing to go to the hospital. And it just seems to me like all along he was declining multiple studies that had been ordered in the past.
So yeah, he really, I think there was, I don't totally understand why, but he certainly was in a bit of denial. And it took, I have to say, it took a lot of arm twisting to try to get this guy to show up to the emergency department. And when he actually eventually did, Jeannie has summarized things here. He had heavily calcified coronary arteries at catheterization. He had a totally occluded mid-right coronary artery with left to right collaterals. He had an 80% left main lesion, 70% circumflex, and 90% mid-LAD. So I think that the learning point here for those who might want to be students of echocardiography is that the chamber dilatation and the extent of the wall motion abnormality really predicted high risk features. Chamber dilatation is really kind of a bad finding. So he also has some modest carotid artery disease. Go ahead.
So he ended up undergoing his cabbage, and he had a lima, to his LAD, saphenous vein graft to the RCA. He had a radial arterial vein graft to his first obtuse marginal. He ended up getting out of the hospital on day 5, but ultimately had, ongoing pleural effusions. And he had one of them, he had it tapped in the beginning of March, actually. And even as of last evening, he still has not gone for his chest X-ray.
So before we go on to the next case, we're doing well for time. I think just to summarize, what this case illustrates is the importance of recognizing high risk features of a stress test. And if possible, if you have a cooperative patient, having them stay in the office until the cardiologist can review things, and the person supervising, nurse, APP, and the cardiologist can come up with a game plan. In this case, I think that we were fairly fortunate that we were able to actually reach him on the phone and eventually cajoled him to go to the ED. So let's pause here. Let's open it up. Are there any questions that anybody has about this first case?
I guess my concern would be, especially as someone who would be involved in this, if the patient isn't willing, because I've also encountered this as well, the patient wasn't willing to stay, and my biggest concern was that the patient walks out, right, and has a cardiac arrest somewhere, and I guess I just worry about liability, especially if you've had that conversation, and everyone is involved, and You can only do your best, right, in having those conversations before they leave, I guess.
Yeah, I agree with you, Bethany. And I suppose at that point, if you have a high level of concern and they're not sticking around, best thing to do is document it. And I guess I would go one step further, is just to verify the information in Epic, their contact information, say, well, okay, we really would prefer to review this before you actually leave the office, and so we can give you the results and decide next steps. But since you really want to go, understand, we just want to verify that we'll be able to reach you at such and such a phone number. Make sure you have their mobile number or their home number, and then document it.
Good case. Thank you for sharing.
Yeah. So, but wait.
Can I ask a question? This is Melissa.
Hi, Melissa.
Hi. So sometimes, with this gentleman, he had, even though he wasn't reporting symptoms on the treadmill, he had really significant EKG changes. And sometimes I just don't know how far to push someone, because, he ended up having left main disease. And
Yeah.
Are you going to precipitate something?
Yeah, no, that's a great question. One could make an argument that we actually pushed him longer than we should have. We saw significant ST segment changes. Maybe we should have stopped the test. He was doing pretty well. He didn't have any symptoms, and you knew that he went 11 Mets in the past. So you're raising an excellent question. There can be an argument made, since he's having ST segment changes that are pretty dramatic, that it would be reason, and he's reached his target heart rate. You could make an argument that you should just stop the exercise and image him there. I will say that you'll probably see a divergence of how people actually handle that situation. And it's kind of just a clinical call at the time of the test, and based on what the patient's looking like.
Thank you.
Question though. It looked like Molly had her Molly, you had your hand up, or she fell off the call.
Can you hear me?
Yeah, we can hear you.
No, I'm right here. I actually had the same question, Melissa.
Oh, okay.
So thank you.
You're welcome. Well,
Very
let's go on.
helpful.
Yeah, let's go on to the next case. Bear with me for just a moment. I'm going to stop sharing for just a second, because I want to set up the Epic for the next case, so we're not waiting as long. Can you read me the session number on this case? That one.
449,
This is the second one. Yeah.
correct.
449
51
51
931.
931. Okay, that's promising.
I feel like I want to just add here that he was so adamant that he was fine and that nothing was wrong, and that he had all these different opinions about, from different cardiologists, and one at Intermed that decided to put him on nitrates. And I listened to him, but that's an excellent point. I mean, in hindsight, stopping the test earlier may have been more appropriate. So I agree. Thanks for the question.
All right, you should be seeing case study number 2, okay? And let's do this. There we go. So now you can see what we're showing here.
Great. So
All
we're
right.
going to go on to our next case. And this is a 82-year-old female, and her primary care doctor referred her for her stress test with increased dyspnea on exertion and chest pain with activity. She has hypertension, hyperlipidemia, and a 45-year history of smoking. Her stress testing had gone way back to 2010, and she had some ongoing dyspnea then, and some ST segment depression, although the leads were not documented, no chest pain. And because of her symptoms or the changes in the EKG, she underwent the gated SPECT test, which showed normal perfusion findings. She was ordered again for a actually stress echocardiogram, and she had gone to the emergency room for some atypical chest pain. She had negative troponins, negative for EKG, for ischemia, and her echo looked great with a baseline normal EF. she was discharged. And then back in the middle of December, she had gone to her PCP with increasing dyspnea, and she had very significant osteoarthritis. And initially the stress echo was ordered. And I think we're all familiar with a patient having an exercise order, and then they come in with like a walker or a wheelchair. And there was a quote, if she can't go on the treadmill, we'll do the regadenoson. You can
Go ahead. Oh, go ahead.
So pre-exercise, we can all see she's in normal sinus rhythm and has a right bundle branch block. Actually had some runs of ventricular bigeminy during her rest. This is stage 1.
So what you're starting to see here already is we're now into recovery here, but you're starting to see ST segment depression in leads 2, 3, AVF. Remember, the patient is supine. Also some ST depression in lead 1 and V5 and V6. Now you still have the right bundle, kind of a right bundleoid picture here to the QRS complex. So it's really hard to judge V4. Usually when you're looking at EKGs with a right bundle and you're looking for ST segment changes, particularly with exercise, this was regadenoson, remember, you discount any changes in V1 through V3. Usually by V4, certainly by V5 and V6, you can pay attention to those EKG changes. They're particularly concerning here because remember that this person is just lying there, supine, and you just have hyperemia or vasodilator physiologic function with the regadenoson. At 3:30 in recovery, Jeannie, you observed that there was the patient was having discomfort in the back, neck, jaw, arms, and you appropriately gave aminophylline. What happened?
She did not improve.
And she still has pretty significant ST depression too. So at this point, I think you gave some sublingual nitroglycerin,
Yes,
right?
so her pressure continues. They were rated 7 to 8 out of 10 and started with the nitroglycerin sublingually. She continues with EKG changes. And after the 5 minutes, her 7 to 8 out of 10 symptoms persist. Another nitro is given and her symptoms decreased. Another 5 minutes and no relief, and given nitro number 3. And by 21 minutes of recovery, her symptoms resolved.
And you also see resolution or near complete resolution of the ST segment changes. So what you're seeing here is that you've removed the regadenoson out of the picture with the aminophylline, right? And the patient's still having chest discomfort and ST segment changes. And I think appropriately sublingual nitroglycerin is being given at that point. And so a couple things there. That scenario really, I mean, chest discomfort in absence of ST segment changes, chest discomfort with regadenoson has a sensitivity and specificity for the presence of coronary disease of 50%. It's a coin toss, okay? So chest pain with adenosine or regadenoson really is kind of meaningless. And it's about making the patient comfortable, getting the agent out of the way so the patient can be comfortable, and that's why you give aminophylline. In this case, though, you have significant ST depression, persistence of the chest discomfort, and eventually, after 3 sublingual nitroglycerin, resolution of the ST segment changes. And so what you're looking at here is truly an ischemic response. So here's the summary. Go ahead.
She had a resting heart rate of 77. She peaked to 92. Her resting blood pressure was 124. You can all see this. And, when it comes to regadenoson, how does the APP, say what the blood pressure response is? What is our peak blood pressure? Is that during infusion? Is that during the test? And I think that these are also some questions that a lot of us, tend to do with what was the highest blood pressure in all?
So it's a great question. So in general, when you give regadenoson, it's a vasodilator, and just like adenosine, for those of you who remember when we were using that agent, you really should see the systolic blood pressure decrease by a bit. And it's usually by about 10 millimeters of mercury on average. I mean, it can be more. And the blood pressure response, I mean, the heart rate response is that the heart rate generally goes up a bit with regadenoson. So we certainly look at that when we're doing PET, for example, to make sure that they're a regadenoson responder. If you don't see any change in blood pressure or heart rate, then you have to worry that they had their cup of coffee in the morning. All right. And then the other important summary statement here is that it really was a markedly positive EKG for ischemia. Okay, I'm hoping that you're seeing a black screen here. And we're going to show you the nuclear images. Bear with me. I hope. Hold on. One second, folks. Okay. In theory, you should be seeing nuclear images here, and you should be seeing a picture of the heart spinning around in front of you. Is that what people are seeing?
Yes.
Great, thank you. So my intention here is not to make you all experts at reading nuclear studies, but I do think that this case is somewhat illustrative. We do look at the CT scans when we look at this. And we do see that there's some coronary calcification here, right here. You look at this is the descending aorta down here at about 530, and then going up into the arch. And you do see significant calcification in the aorta. So the more calcification you see, the more likely it is that you have obstructive coronary disease. But in general, coronary calcification does not equal obstructive coronary artery disease until you get above a score of like 400. This probably does get there. And then we'll look at the images here. I'll make these look pretty for you. We usually use a couple of different pictures, images. So, so what we're seeing here, this is the horizontal long axis view. So we're slicing the heart horizontal to the left ventricle. This is the septum, apex, and lateral wall.
That's the stress on top, is that right?
That's correct.
And below it is the rest.
That is correct. So these are stress images here, rest, stress, rest. And up here, you have two sets of stress, rest, in the short axis, sort of reminiscent of that stress echocardiogram. So on these short axis images, you've got the anterior wall, lateral wall, inferior wall, and septum. Here on these vertical long axis slices, you've got the anterior wall, apex, and inferior wall. So these are just the raw native pictures, and then we can apply what's called attenuation correction using the information from the CT. And that allows us to correct for problems with attenuation. And what's interesting about this study is I'm going to go back to the non-corrected. You're really not seeing a whole lot here. You just see this kind of see, this is kind of like orangish color, and here it's yellowish. Okay, and if you're looking at this, so it goes from yellow back down to orange. This is an ischemic defect here, and I have to say, when you're looking at this, it's not quite as extensive as you really would think. Now, the other thing we look at is thinking back to that first case is what's the size of the left ventricular cavity? Is it big? Now, we have a way of quantifying it with what's called a TID score. I won't go into it in great detail. This actual quantification is normal, but visually I'm looking at this and I'm going, I kind of wonder whether this cavity here compared to this cavity here is just is slightly larger. Didn't turn out to be quantitatively so, but it's just my visual impression that it's a little concerning. We also look at quantification and polar maps. So polar maps, these polar maps are done by taking these pictures, you stack this one on top of this one on top of that, this one on top of that, that one on top of that, and you squash it down on your desk. Much like, you know, if those of you are hikers or campers, if you have a camping cup, the cup is the heart. You're sipping from the base of the heart. The water is held at the bottom by the apex of the heart or the bottom of the cup. When you squash it down, you look at it and you got a bunch of concentric rings, and that's the polar map. And so what you're seeing here is this little dark area here, and it becomes more normal here during rest. So there's a little bit of reversibility there. And this is kind of suggestive maybe of a little bit of inferior ischemia too, but that might be attenuation. So we look at the attenuation correction and it does correct. Pay no attention to the apex on the attenuation correction images. We have an issue with our camera. Looking at the quantification though, this does show that there's an abnormality there near the apex that normalizes. And we can also look at LV function. Her function was actually quite good. EF is 75%. And we can look at it in 3D. That looks nice. I can spin it around here. And you can see that it's coming in well. All right. So I'm going to stop sharing that. I'm going to go back to our presentation. All right, you should be seeing a black screen. Take it away.
Okay, so she went on to cardiac catheterization, and you all can see here that she has quite significant multivessel disease, including her left main, LAD, her circ, and her RCA. She has normal LV function and mild aortic stenosis and mild to moderate regurgitation. And you can see there just a mild mitral calcification and mild stenosis. So the surgeons, took a look at her cath, and, given that she's quite young, which is not the case, and the calcified aorta and her decreased mobility, at that point, she was looking to have something taken care of with her knees and was walking very poorly. And the CT surgical team did not really feel that she was a good surgical candidate. But Carol herself, she didn't want to undergo a procedure which could take away some of her independence, and her independence was the most important thing. There was a discussion held at the hospital, and she strongly desires DNR, DNI status. Ultimately, initially, she was referred to the CTO clinic, and ultimately she decided that she was going to cancel that, and she's under our care here. And currently she's doing well. She's tolerating the aspirin, she's on low dose isosorbide, and she's taking a beta blocker.
As well as I think she's also on lipid lowering therapy.
Yes,
well.
And she is on a statin. Thank you.
Yeah. So I think what this points out is this is another case showing high risk features. Here, you get more concerned about the EKG than the stress images. The images give you a hint of what might come based on the coronary calcification, based on a qualitative assessment of some transient cavity dilatation and on an ischemic defect. And so that was those were the flags that prompted us to recommend that she go to the emergency department. So at this point, we'll open it up for further questions and discussion.
Dr. Cohen, do you want to share a little bit about what this presentation brought up about our teams downstairs, the nurses and
Yeah.
the APPs? And
Yeah, that's a good question, Jean. A good prompt. I do think that, one of the values of Maine Health, not to get too highfalutin here, but is respect. And if you have a concern, you should feel safe in bringing that concern to the physician who's, the supervisor for the day there. And there should be a professional dialogue about those concerns, plus minus maybe even some teaching involved. In these cases, I think that there needed to be a professional discussion with the cardiologist before the person left the office. We did hear in the first case that the person wasn't willing to hang around, and the second, certainly she was. And you come up together with what the plan is going to be. And in both cases, they were sent to the hospital. I think the other thing that both of these illustrate is the importance that we've had a lot of new faces join our team, both here in Scarborough, at the hospital, and across the health system. And there are varying degrees of experience and comfort with stress imaging. And so I think what we're going to be seeing in the coming months is not only standardization on the qualifications to supervise tests, but we also want to do a lot of education around that. And for those of you who are in Scarborough, I think you're going to probably see a number of people rotating through our lab from some of our regional sites in order to gain greater experience in supervising tests.
And the last piece of that would be that as a team, the goal is that we have a bit more of a teaching reference and updates of our standards, and so that we can all feel that we have guidelines to follow, and especially in patient populations such as the HCM, for example, or degrees of aortic stenosis, and just to have a bit more consistency, because I feel like we're an excellent team. And as APPs and nurses, at times we get different plans of care from different cardiologists. And so I'm very pleased with the teams that we have. And as a goal, we're going to generate some protocols, and not necessarily rules, but guidelines to assist us with teaching those coming in, collaborating with peers, physicians. And this has been a good eye-opening experience to get that started.
So to that end, we're actually going to be convening a group of people from both the Scarborough office and Maine Medical Center to start reviewing the reference materials that we have available, which are supposed to be in all the stress labs that we've discovered have disappeared from a number of them. Recreate that, and also recreate a compendium of teaching materials for students as well. So that work is going to be getting started very soon. I'm hopeful that we can do that work and complete it rather quickly, get it out to everybody, not only in printed form so things are at your fingertips, but also in electronic form in a central location so people can access that. Not only here, but across the system. And eventually we want to also involve our colleagues across the health system in kind of finalizing these reference materials. So we're going to pause there again. Just want to know if anyone else has any questions or comments that they want to make. Hopefully you all found this helpful, instructive, interesting. I once again want to tip my hat to Jeannie for putting this on, and Andrea for getting you all together on a Zoom call. A lot of work went into this. Jean did a fantastic job. I want to
Thank you very much.
Questions?
Molly.
I had a question about performing stress echo in patients with known CAD. I think this question has come up several times during clinic. When patients have come in with existing CAD for a stress echo, because the sort of the conventional understanding has been, if you have CAD, you should get it nuked. But I don't know that that's necessarily true. I just wanted to know what your opinion on that was.
Great question, Sam. It all comes down as to the indication of what type of information you want to get out of the test. So if you're talking, that you have coronary artery disease, but the question is the significance of mitral regurgitation and whether the person, whether it's time for the person to maybe go to surgery for their mitral disease or aortic valve, for that matter, how severe is the aortic valve, then it may not be a nuclear stress test that's the appropriate test for that patient. It may be a stress echocardiogram. And even then, most cardiologists and most of you have a greater comfort level with treadmill exercise, but for valvular heart disease, actually, supine bicycle ergometry is probably a superior test for a lot of reasons. I look at it as kind of an equalizer for the skill level of the sonographer. You're not quite as rushed to get your pictures, and you usually get superior pictures when you're optimally positioned while you're exercising, and you're getting the pictures during stress. So that's a great question. The old saying is, when the only tool you have is a hammer, everything's a nail. But as we all know, patients come to us in various sizes and shapes and with various clinical questions. And so we have to pick the appropriate test for the job that we have at hand.
Thank you both. This was a really great talk.
Great, happy to do it.
I'm certainly grateful for my peers for attending this morning. So thank you very much.
Great, thank you guys. This was really good. I will upload this to Canvas, and whoever doesn't have access to our monthly Canvas, I can include a link as well by email.
Thank you. Have a great day.
Have a great day, everyone.
Thanks, guys.
Thank you, guys.